Okay, so just continuing from where I was, everything, I've already been in here the whole time. I'm just gonna knock out a couple of things I may have not assessed well enough. So just going back to the pain that the patient was having in the wrist, I want to ask a couple questions. Basically, PQRST is a mnemonic that we use. So the provocation, what happened, the quality of the injury, does it radiate, is it a dull pain, is it sharp? And then I just want to ask you, what your pain is, scale to 1 to 10, you gave me that, and kind of the severity. It looks to be a closed fracture, and hopefully, if even a fracture, and the x-rays will show if it's complete or incomplete. That'll be up to the doctor. So I want to assess that for charting for the injury, for the pain. And then with the pupils, I wanted to also just have you follow this with your eyes so I can see that your muscles are working okay. And you're not having any vision problems, are you, Mr. Hunt?
No.
Okay, so you can see those numbers over there on the wall?
Yep.
Okay, and then up close, can you see this number?
Yep.
Okay, good. So no vision disturbances. And then with your mouth, everything looks good, you're young, healthy, but oral care can come into play if it looks like the patient's not taking care, there's white thrush or anything like that. The whole time I'm assessing the skin, especially in this injured arm, I'm assessing the skin for the color, the tone, the temperature, and kind of the skin. Is it thick? Is it thin? Is it intact? Is it dry? Is it chafy? And then if it doesn't cause you too much pain, can you grasp my hand here and here? And this is just checking some neuro that I may have missed earlier.
That's a good sign.
And
I'm also going to check for mobility if my patient.
Oh, and lastly, let's just go ahead and pretend that this is a female. So for female, when was the last day of your missed period? Or when was the last day of your last period?
A few months.
And she said it was on the 28th. So that's great. And do you want to talk to anyone about contraceptives? Are you using protection? You know about all that? Okay, good. And how about the discharges? Is there anything abnormal coming out? Any odor? Anything foul? Okay, no. And then your period, is it long? Does it last a long time? Is it, is there a lot or a little blood? Okay, everything's normal with that. And then when examining with my gloves on, I can basically just pull apart, and I'm just looking for any growths or anything like that that's in here, in the labia majora and minora, and I can get a look at the anus now too, and everything looks good. And then if you want, we can talk about any sexual problems or dysfunctions or anything like that. And so that was all the stuff that I may not have grasped besides mobility. So I would have you stand, if that's okay. Can you stand on one foot? Can you stand on the other foot? Can you walk to the end of the room? Okay. I want to see how you can hold your balance and checking your gait. Are you feeling any dizziness when you stand? Any lightheadedness? Okay, good. So no trouble with that. No trouble moving or anything like that. So I wouldn't really think that my patient would be a fall risk based on this information. And then for the Braden scale, I'm just gonna assess, if this patient, upon admittance, you always want to do a Braden scale. This patient is pretty much coming in and probably gonna leave, but still we could do one. So the different areas that I'm looking at are the sensory perception, the moisture, the activity, the mobility, the nutrition, the friction and shear. And so we kind of went over this. So basically, potentially like bedbound patients are going to receive scores. The higher the score, the better. If the score is low, like less than 19, that would be a patient that really needs to have their skin assessed at least every 2 hours, and turned and whatnot to make sure that there's no pressure ulcers forming. and so there's 4 stages. And so when you see the redness, you're always assessing for the blanching, and then if it does not blanch and it stays red, that indicates that the blood is pooling and that they're very susceptible to having a breakthrough, and that's a stage 1 pressure ulcer. With the sensory perception, are you limited at all? Can you move? I'll ask that. The moisture, is this patient continent, incontinent? And are they diaphoretic or anything like that? No. And then activity. So are they confined to the bed? Are they bed bound? No, they're not. Can you feel this? And can you feel that would be for my sensory. So if they can't feel the area, then, right, they don't know that it's hurting or that it's potentially developing a sore. So then that would give them a lower score. The nutrition, is my patient on total parenteral nutrition? Is my patient eating well, healthy, no diabetes, anything like that? So if the nutrition's really bad, then the skin is very vulnerable and also would give it a very poor score. And then the friction and the shear. So this kind of has to do with just kind of the sliding and are they having to get in and out of this. So especially as a healthcare worker, I want to make sure that the patient's nice and safe when we're moving them around. Using the if let's say my patient was unconscious, I can use the faces pain scale, and I can kind of look for grimacing. So this is the scale here, and you're basically, if you can't ask a patient to rate their pain from a 1 to 10, then you're going to go by the faces. And so just looking at my patient here, I wouldn't say they look particularly uncomfortable, but I also would, am always concerned about patients that are unconscious. And so I would kind of hold this up and sort of see, like, what does my patient look like? They don't look outwardly miserable, maybe a 3 here. So then that would be, maybe between a 2 and a 4. So that's the faces pain scale, comes in handy again for patients that are having a coma. And then lastly, the Glasgow coma scale. And this is a really great technique used for patients who have head injuries. Also, lots of times you'll get a score in the beginning, and your score will be very, very different than it is hours later, and that's really because of the increased intracranial pressure causing ischemia in the brain, and then those blood vessels not being able to work, and then they die off. So upon any head injury, you always want to do a Glasgow coma scale. It's pretty universal in the hospital, and what we're looking for is the eye-opening response. So you're trying to get as many points as you can. The point range is
and also his mobility, able to move around in bed. Signs of friction.
Okay, so starting with the eye response. You're seeing if it's spontaneous, if there's no response, if I have to wake the person up, then that's a different score. And then so I'm scoring it as I go. And then the verbal response, so are they oriented? Can they talk to me? Are they confused? That might indicate a head injury. Are their words inappropriate? They're saying weird things like you do sometimes when you're dreaming, or I can't understand. Are they slurring? This could indicate a stroke, also ischemia in the brain. And then their motor response. So can they respond to moving and flexing and moving and all that. And so I'm scoring them out. And it's out of 15, and so anything less than 13 is definitely of concern. Anything like around an 8, I would consider a patient to be comatose. And so again, yeah, are they responding to verbal stimuli, to physical stimuli? Are they just responding? So that's really comes in handy for head injuries, and those are frequently assessed right after, immediately after the injury, and then moving forward. So yeah, that's pretty much good for me. So yeah, same wrap up as before. Head lower, documentation, scoring, cut.